So I wanted to welcome all of you. This is really an exciting event for us on the board. We learned so much from you about this. This is a mutual learning experience, and and so much of an opportunity to learn internationally from one another. That's exciting to me. I've lived in Sweden, I've lived in Italy, and just the idea of having the opportunity to learn from one another is really um, just a wonderful thing. And so, Active Surveillance Patients International, its purpose is to help men navigate active surveillance, educate men on the latest technologies, and really to learn from one another. In my case, I uh, I've been on active surveillance for 16 years, and I've learned so much in these past 16 years and watched the evolution of active surveillance. And uh, gosh, if active surveillance evolves this much in the next 16 years, it's staggering to even imagine that. Part of our thing, too, by the way, is that there's a lot of wasted time and effort. I had a lot of wasted time and effort on anxiety initially, and it's not surprising that men diagnosed with cancer are going to have a lot of anxiety, and hopefully through our work we may be able to help you to reduce your own anxiety, because all of that, in my case, all of that anxiety was pretty much a waste of time and effort. Um, too, in terms of the evolution of active surveillance, it was just 4 years ago that it was almost unheard of for somebody to there was a 3+ Gleason 3+4 to go on active surveillance. Now it's pretty common. So we see things evolving very quickly, and we're hopeful that by the end of the call today, you might feel just a tad more comfortable than you are right now. Um, and I think humor too is a way that we can lighten our load. And so I try to weave that in a little bit. And so, in honor of Dr. Bangma, I want to include a Dutch joke. Why are the Dutch people so tall? It's because the shorter ones drowned in the floods. In any event, I want your feedback. We want your feedback, and two, was there everything from how our notice was to how the meeting went, and any feedback we welcome. So with that, I want to introduce my dear friend Howard Walensky. Howard is a remarkable uh, guy, an old newspaper reporter, prolific author. But too, he's become a very dear friend of mine, and that's one of the things that's really unique about this active surveillance journey. You begin to find friends that you would not otherwise have had the opportunity to make connections with, and that's been a great gift. So with that, Howard, you're on.
Okay, well, thanks, Mark. And we should also acknowledge in the audience Throne Thorvaldsen, another one of the founders of ASPI. Any rate, as a co-founder of ASPI, I'm honored to introduce our first program featuring a doctor who has changed for the better the lives of men on active surveillance for prostate cancer. 4 of us on active surveillance started ASPI 4 years ago with the vague idea of building bridges with other men on active surveillance around the world. And so from my point of view and our point of view, this is sort of an historic moment because we're making this happen with your help. We saw a need to learn and understand how active surveillance is practiced around the world, and there are differences, as you will hear today. Our hope is to find the best practices and share them ultimately to improve patient care back home, wherever we live. And we're thrilled today to present Dr. Chris Bangma, chairman of urology at Erasmus University in Rotterdam in the Netherlands. For the Europeans in the audience, Chris is known as the father of active surveillance in Europe. Let's put it this way for Canadians and Americans. Doctors Peter Carroll, Lawrence Klotz, and Valentine Carter are the Dr. Bangmas of North America. In any case, Chris is a world leader in active surveillance. Hello? Hello?
Just keep going.
Okay.
We can hear you fine.
Okay, since 2010, Chris has been the principal investigator of Movember's Global Action Plan 3 on active surveillance for prostate cancer. Chris will be telling us about that program and why he's hoping that you'll help his effort, our effort, with the questionnaire. I'll post that in the chat. Chris is well known worldwide for his contributions. He is past president of the Dutch Association of Urology. He is widely published in the medical literature, having contributed to over 200 papers on prostate and bladder cancer. And today, he will be addressing the past, present, and future of active surveillance. So with that, Chris, it's in your court.
Thank you very much, Howard and Mark. I will go and share my screen for the slides to present. Thank you very much for the very kind words you said about me. Of course, some humor is very well placed. And it was only today that somebody on the Dutch radio told us that the word tumor rhymes with the word humor. I would like to show my slides, and I'm just going to the first one. And here you see my name. I have been introduced. Too much honor of being called the father of active surveillance, because so many people are contributing at the moment in Europe. And I'm very glad that the program has been widespread amongst European countries. If you want to discuss things with me, feel free to use my email. It's in the right hand top corner, and I will do my best to answer you as quickly as I can. If we are talking about cancer, then most people, maybe also amongst our afternoon session of today, just realize it's 6 o'clock almost here in the Netherlands. They will say cancer is something horrible. It kills people. It's growing everywhere. It cannot be controlled. From the view of a biologist nowadays, one would say, well, cancer is just a disease of the DNA. The DNA are those molecules that are responsible for the reproduction of cells, therefore of growth, and for the function of cells, therefore of their well behavior. And they can have a flu, and the cancer is not very intensive, or they can be completely disarranged, and then of course the cancer can be aggressive. So that's another view, and I think that we have to face the various views on cancer and the various phases of prostate cancer, especially this afternoon. If you ask a pathologist, then he will look through his microscope and he will start grading a cancer, whether it has a very nice face, like the famous Vermeer picture at the left, or whether it has a almost horrible and disarranged face, like the Picasso almost on the right, and every shade in between is feasible. If you ask a doctor or a patient, then they will talk about risks. What is the risk of metastasis? What is the risk that I'm getting a horrible disease with symptoms, even die of it? So they will talk about risks and prognosis. And if you ask an epidemiologist, then he will say, well, where is the cancer? Is it that bad amongst the world? Are there differences amongst the world? And we will address that. So let's look at the face of the cancer by the eyes of the pathologist, and the eyes that you are familiar with because everybody that is having a prostate cancer will know its Gleason score. And the pathologist is looking at the cells and the dearrangement of cells. Now, if the cells are looking very much like the glandular tissue, the normal tissue of the prostate, with only very small dearrangements of the cell nucleus, then they will say, well, it's low risk, it's well differentiated. It looks like a pretty picture. There's nothing wrong with it. If you look at the bottom side, then it's almost not recognizable as a face or as a prostate cancer anymore. And therefore, that is a very high risk of getting metastasis. It's anaplastic, it's poorly differentiated. And it is an aggressive disease that needs to be treated. Nowadays, for few of you, you will be familiar with a new kind of score. It's called ISEP score. It's actually originating from Johns Hopkins, but it's being increasingly used amongst pathologists and urologists around the world. If you haven't seen it before, don't bother. Nothing new in it. It's just a rearrangement of few microscopic views on the cancer. If you haven't seen it before, forget about it for this moment. Now, the epidemiologist will look at the incidence, and the incidence is being depicted as the annual new cases amongst the population. Then you have the word prevalent, that is how many people of cancer are there at a certain time frame. Because if there's 10,000 new in a year, there might be 70,000 running around with prostate cancer. For an epidemiologist and for patients also, it is important to know what is the annual growth, what is the expectation of cancers and also new cancers around the world or in a certain area. It might be a risky area, or it might be an area at low risk of getting more cancer in due time. And then, of course, you will compare the incidence of the prostate cancer with other cancers, because that will highlight its importance for governments, authorities, other stakeholders like industries, etc., and also for organizations to put yourself on the front line. This is a world globe of the incidence of prostate cancer. How often do you see new cases annually in a certain area? And as you can appreciate well, North America and the center of Europe and Australia are very dominant in new cases. While, for example, in Japan, China, and the Far East, the incidence is very low. And remarkably, also in the middle of Africa, there's a high incidence. Now, how come? What is the reason? Is cancer more prevalent? Is there more cancer in North America compared to the center of Africa, of the African continent? Or are there other players or arguments that cause this picture? We can argue, for example, and we know about it, that the food, the low fat and consumption of meat in the Far East is definitely being correlated with the low incidence of new cases of cancer. Cancer is there, but it simply doesn't grow. While, for example, in the center of Africa, we know that the genetic pattern of cancers and of men having prostate cancer is different from cancers in other areas of the world. So it's just to show to you the world is not one unity, and there's multiple arguments to see different patterns around the world. Now this slide is somewhat different. The top slide can be compared with the latter one. The dark areas show the incidence, but remarkably, the lower slide shows you how many people die of it. Then you see that from all the people in Africa, most people die of it. So there's something in genetics over there, or lack of care, or feasibility to find a doctor that can treat you well. While, for example, in the United States or in Australia, the mortality is much lower. So this discrepancy of finding cancers while not dying of it is very dominant for the distribution of these numbers around the world. And the way we're looking at cancer. The epidemiologists are looking at cancer. As you can appreciate also from this slide is you can be found with a cancer, but maybe a third or even less people are dying of these cancers. Okay, this is the relative importance of prostate cancer compared to other cancers. As you can appreciate, this is a timeline from 1930s, early registration till 2015. And because of smoking, you can see that the highest incidence of prostate cancer mortality, cancer mortality is in lung cancer. And that is because of smoking. And with the decline of the use of cigarettes and tobacco, also the mortality goes down. In prostate cancer, we see up back in the 1995. That was at the time that PSA was invented, and many people started screening for early detection. Many cancers were found, but not all treatments were started as yet. But afterwards, you can see it declined dramatically up to a level that is comparable to the mortality back in the 20s of the last century. And this is due not only to screening, but definitely also to better treatments, maybe earlier treatments of prostate cancer. And that there is a big interest because prostate cancer is the second cancer in incidence amongst the graphs that we just showed. That is good, of course, for those people that are having a prostate cancer because they know that the industry and the doctors and the authorities are taking care of prostate cancer research and the development of new possibilities to treat the cancers. And this is an estimate of the money that is going into this research of treatment modalities. And it shows to you that there's definitely, although the mortality is going down, the interest, the financial interest of industry is going up. And it has to do that people with prostate cancer live longer, they're getting older, and it's very likely that they get into some treatment at some point that is of interest for the market. Not too much about markets. You are familiar with the fact that when there is a cancer that is aggressive enough to be treated, it can be done so to cure a patient by surgery or by radiotherapy. But if you escape from that and if the cancer cannot be cured, then you run into the palliative options that are so interesting for so many people, landing into endocrine therapy, which we call testosterone stop nowadays, because castration is such an ugly word. Chemotherapy, sorry for the misspelling over there. Immunotherapy, we have virus-based therapies. Well, there is a lot to come, and I've shown you the interest to develop things. Most people, most patients, or most men are just afraid of the end stage of prostate cancer. What is it? Pain, suffering, feeling bad, social isolation because people around you don't dare to discuss cancer with you and avoid meeting. Side effects of treatments, also of earlier treatments, of radiation therapy or surgery, but especially also of chemotherapy and other systemic drugs. And becoming dependent on your direct surroundings, your family, but also people around you, or maybe financial issues. All of these things we hope to escape. And we're trying to do so, of course, by early detection. That is why most of us are sitting here, because we had an interest of avoiding the end stages of the disease. If these end stages wouldn't be there, we wouldn't care. Yeah, we wouldn't be interested in prostate cancer. But as we know that many people can run into these horrible end stages, we like to avoid it by preventing it. And we feel that we have to diagnose early. But then we run into the question whether every cancer needs to be treated. Every cancer diagnosed needs to have a treatment that is invasive. Because when it wouldn't bother me, why should I start a treatment? And that bother is, of course, dependent on your life expectancy. When you're 85 with a horrible disease, second disease, and you have a life expectancy of less than 5 years, prostate cancer is the least for you to bother about. But if you're 50 years old, then of course it's of significance whether you're going into an early treatment in order to prevent this late stage disease, and what will be the reduction of the quality of life by doing so. So these are pivotal questions for people, and over the years now, with the experience of prostate cancer from the 90s onwards, we know that most of us sitting here belong to that part of the population of prostate cancer patients that is depicted by the snail or by the turtle slow development, which is very unlikely to develop symptoms even when you run to the end of your years. But that there are, of course, aggressive cancers that need to be treated because their natural course is ugly. So how did we get to know all these things? Because as Mark mentioned in his introduction, for the last 15 or 20 years, we got to know a lot about the growth and the nature of prostate cancer. And it all started with these studies on screening. There is this screening in Europe, the European randomized screening prostate cancer, that has become very famous. And there was a study in North America, the prostate lung colon ovary study, that studied, of course, early detection in many cancers, that came to the conclusion that the face of prostate cancer can be ugly, but very often, definitely when you screen it, when you go for early stages, asymptomatic stages, that there is many cancers that are of very low risk. The effect of these large studies were that you can reduce the mortality reduction if you screen early by more than 20%. And now this seems to be a lot, of course, but if you look at the incidence of the prostate cancer, of course, on the population base, this might be something like 1% of the population that can be in which the mortality can be reduced. More important for people that are living and want to avoid this at the end stage is the reduction of metastasis, and early screening, early treatment reduces the number of metastases dramatically. But there is a price to pay, and the price is that for every cancer that is being detected and being saved for dying of becoming a mortal cancer, a lethal cancer, we have to do 20 prostatectomies or radiation therapy. So 90 out of these 20 people are not being served to prevent that one death. Of course, 10 of those maybe do not run in metastasis. And that is the good news, of course. The bad news also is that the early treatments have side effects. And everybody is familiar, of course, with the side effects of surgery, being potentially incontinence and loss of erectile function, and the enteral problems, the gut problems of radiotherapy. And then there is this overdiagnosis, because as I mentioned, in early detection programs, almost 50% of the cancers detected are indolent, are low risk, are the cancers that are present with people that are listening to this presentation today. These are the sleeping tumors. But the risk of these sleeping tumors is that everybody gets far too anxious to treat, far too nervous about progression. And therefore, overdiagnosis introduces also overtreatment, apart from the anxiety of the overdiagnosis of these sleeping tumors.
Hey, Chris, one second, if I could interrupt. This is Mark for just a second. Your sound is okay, but a couple of people said they were having difficulty. So if you could just slow it down just a little bit and just continue to enunciate, then those folks that are not native English speakers, I think, would be well served. But it's good. All this is good. Just a couple of people have emailed. So thank you.
I'm very sorry about the sound quality. I apologize for that. It definitely has to do with my computer software, I'm afraid. And I hope that by slowing down, I will make myself clear. Are all cancers really so dangerous? Are all cancers wolves in sheep's clothing? Well, I think we've seen that it is not true. And actually, 40 years back, we already knew that, but we had forgotten the story. At that time, around 1985, many people with enlarged prostates were operated because there were no drug available at that time. And they were operated by a TURP that gave that less obstructed their prostates. And often, histologically, there were cancers being found that were mimicking the nice face of the cancer, and therefore were left alone. These patients never were checked for cancer anymore, only for their avoiding, but not for the cancer. With the invention of the PSA in the early 90s, we forgot about it because everybody was focusing about this tool being used for screening. And that was the era in which these large, enormous screening studies started, but we needed many years in order to get the results of it. But during these studies, it was found that so many of these low-risk cancers, looking like the 1985 cancers, were being found. And therefore, the eminent professors like Klotz and Peter Carroll started the idea of observing these cancers better in order to understand the disease. Here in Europe, we started the so-called PRIUS initiative, and that was an initiative also based on the knowledge of North American and of the European screening study about active surveillance. And Professor Rogohl and I, and at that time, Professor Fritz Schroeder, who's quite a familiar name to many of you, started this enterprise of PRIUS in Europe. And very important for this, for these events was that after a few years, active surveillance was accepted in the physician community of urologists and other doctors, as well as most patients. And so many scientific results became evident in order to put the programs and the monitoring of active surveillance into guidelines. And these guidelines not only served for patients to get information, but also for physicians to get less anxiety and to offer active surveillance because they were covered by the experiences that led to the guidelines. So very important. Because anxiety, as Howard told us, is the main frame on which we are serving at this moment. And everybody can understand this picture and can feel it emotionally very well, that everybody is afraid that something will start and initiate our cancers of low risk becoming more risky and more aggressive and progressive. So at the beginning of all these programs, what were we afraid of? We were afraid that finding a cancer, we might have missed a more aggressive part of the cancer hidden in the prostate. We did not know exactly how these cancers, although classified as low risk, would act in 10 years' time. We would like to have a prediction, especially because we were early in the diagnosis. We did not know exactly how often we had to check patients and what the timely recognition could serve for. Were we in time to offer still a curative treatment instead of treatment that would lead in the end to metastatic and palliative treatments? And what would be on that time the quality of life of patients on active surveillance? So all the reluctancy of physicians and patients in the early time of active surveillance was around anxiety, but it was also about market mechanisms, because often doctors like to treat better than they would like to wait. It was also about, especially in Europe, the lack of cost reimbursements. Doctors had to check patients annually, also with biopsies and other tools, but we were never reimbursed because there was no treatment given. Active surveillance was not seen as a treatment. So it took very long before this was restored. And then there, of course, there was always the anxiety of legal claims, as you can see depicted in this picture a little bit. Anxiety with the pilot doctors of not being in time, seeing a flickering light of PSA going up and warning everybody that there might be some progression of cancer. And if they would not recognize that in time, they would be sued by some kind of a patient or whatever, being too late and having offered active surveillance. So these were the difficulties of the early stages of active surveillance. Now you are familiar with the 3 stages of active surveillance: the identification of the low-risk groups, the follow-up on the protocol, and if a reclassification leads to the recognition of a more aggressive disease, what to do. Some of the patients will decide that they have not the life expectancy to have any gain in being treated actively, and therefore they start watchful waiting, just doing their PSA every year and see what happens, and going into palliative treatment if needed. But often, because of their age, of their comorbidity, their other diseases, they will never come to that stage. Most of them will go into radiotherapy or radical prostatectomy because their life expectancy is more than 15 years. And some of them are recognized too late, unfortunately, and they run into systemic therapy with the testosterone stop as the first thing to do. Now, we've seen that on active surveillance, 50% of men will land up in category 3. They will run into a decision to go for a treatment. But only very few, as far as we know now, around the world, will end up dying, in fact, of their escaped prostate cancer, recognized as early as low risk, but misclassified in the end and being aggressive and not being able to handle this curative disease, curative intent. But as far as we know at this moment, this risk is reasonable low. The identification tools we have is rectal examination, a very crude tool, the biopsy, which is very essential, and which needs the eyes of the pathologist. Nowadays, since a couple of years, the MRI and other forms of imaging, and to come genomic tests, which are available in Northern America, once again, in Europe, hardly being reimbursed, and therefore not being used. We do not have any experience with it. Before this meeting, some of the people asked me, and what about confirmatory testing? And I only want to highlight that the issue is not, to my opinion, as big as it looks like, because the tests we are using today are not the same tests that we were using yesterday as MRI has been introduced up front. The confirmatory testing was actually only for referral patients at the time that many physicians did not want to use active surveillance and referred to the academic institutions to put patients on protocol. And there we found out that the patients actually were not classified well enough because they did not have sufficient biopsies, or the biopsies had to be reviewed, or there were any other arguments to do a reconfirmation of the initial identification of the tumor. And up to today, we still call any testing within the first year of active surveillance a confirmatory testing. But that has also to do with our observations, because if you want to look at this, let's say this race of tumor, we'd like to observe it from an equal start in order to interpret the results of the outcome of the tumor in the same way from the same starting point. Good. There are many different protocols, especially in Northern America, that are being observed as rather different, but maybe in the end are not so different at all. Pivotal in all of these protocols are the repeat biopsies, and they are the most important factor for classifying the status of the cancer at that moment. Please interrupt me once again. I see chats coming in, but I'm not reading them. So if of importance, please let me know. In the first stages of active surveillance, so many years back, we thought that PSA was important. But we happened to learn that the PSA and the changes of maybe other urine markers are indicators to do better diagnostics at the time, but definitely not indicators of going into active treatment. So it's like a warning light. Imaging nowadays, although not fully validated, in many areas of the world is pivotal. Also in Europe, but definitely also in Northern America. It is well available and it supports the initial recognition and classification of your prostate cancer, but it might also serve in the follow-up. As of now, there are some protocols that you are using this, but more to get data in, because I can say pretty sure that the research community around the world is definitely not unanimous about the value of the MRI during the monitoring. And maybe we can discuss that later with more questions about it. And then the upcoming of genomic markers, as we are testing those, there's a large research ongoing between the institutions of Peter Carroll, Lawrence Klotz, the Prius in Europe, the Freiberg centers in Australia, but also with cancers from Finland, Sweden, that are bringing together materials in order to find out the value of the current genomic testing. But we have to regard all of these tools as elements that contribute to a certain risk. And keep that in your mind, because risk assessment is going to be pivotal for the future of active surveillance. So these protocols are numerous in the United States, but slightly different. There are very strict protocols, like every year a biopsy, and only lesion 6. And if you have a lesion 7 or more than 3 or 4 positive biopsies, then you are being offered treatment. But there are also more flexible protocols that include, for example, the Gleason 3+4 is 7, as mentioned at the introduction, or protocols with a 3-year interval. Now, is this bad? Do we need to harmonize this? Because if it's strict, it's very safe. and that's probably 0% that go into metastasis. If it's more flexible, then many more people can be included in active surveillance, avoiding side effects of treatment, but they run the risk that they are in the 2 to 4% of the metastatic disease that leads to cancer death, being reclassified too late and therefore obtaining a non-curative treatment. But the question was, can we harmonize that? Is that necessary? I mentioned priors in Europe, and we thought at a certain moment in 2005 that it was necessary to combine all the initial active surveillance initiatives in Europe. Those were the early stages in which it was just recognized that screening led towards low-risk cancer. And we introduced a program that, because we were so early, was involved in very many practices in Europe at an early stage. And as you can see, we have been very successful with this program all around the world, actually. Also in the Far East, Australia, and even in Canada. And at this moment, the database includes over 9,000 patients on active surveillance. Which made it so popular was the initial website, still existing and serving patients as well as physicians, that was easily accessible in many languages, and that showed on a unique base to the patient the progress of their tumor and the possibilities for diagnosis and intervention. It was this website that, for example, showed tables of fixed protocols, but also showed your PSA and whether the PSA was unacceptably fast increasing, that would indicate extra diagnostics. So this was a tool that popularized active surveillance amongst physicians as well as patients. And we were just lucky to be early in order to get a harmonized protocol all over Europe. Therefore, this protocol is also the largest in the world. But it came to a stage in which we thought that the variation of protocols could have a large value because we were able to compare different protocols around the world. And that's how the Movember GAP3, Global Action Plan 3, started, based in Rotterdam, with collaborating with over 30 large institutions all around the world, especially academic centers with an area of active surveillance clinics around it. And up to now, we have included in our database 20,000 men, which we observed, and therefore we have been able, during the last years, to compare the protocols on statistical basis and to conclude about the best treatments in certain areas. So just giving you the overview. The initial phase of active surveillance was crude. It was a fixed protocol based on biopsies, recent sticks, nothing else, and that was it. Still, many people were served. Many patients were served with it, and it did actually very well. We improved on it after the histology and biologic phase to a more image-driven phase, in which MRI has become very important, although we do not know the definite value of it as yet for the monitoring. But as you can see, over time, large efforts have been made on a worldwide base in order to improve active surveillance. So patients and physicians can feel more safe because there are more people studying, observing, and improving. So this is actually depicting the stage in the early phases in which biopsies were central issue. And this is the stage where we are now, in which MRI gives us the opportunity to target lesions and to avoid lesions that we would miss by blind biopsies, and that would involve lesions with a higher Gleason score and being more aggressive. So we're improving at the detection level. So I'm going to give you 5 slides now that shows you a summary. Where are we now? As doctors, we are being told we are initiating our careers with the oath, do not harm. Do not harm patients for your own benefit. It's a very old traditional oath, but with screening, with the best intentions of prevention of aggressive disease, we are also making victims. And those are the patients that are being diagnosed with harmless cancers and that will never live up with symptoms. And we need to be on a constant basis aware of that. PSA awareness, the possibility of testing PSA in your blood and finding a cancer brought screening. Screening brought mortality reduction, but the flip side of the coin is it also brought overdiagnosis of indolent cancers. Indolent cancers run the risk of bringing overtreatment, overactive doctors, over-anxious patients. And overtreatment therefore introduced active surveillance as a guideline, being monitored from a safe base. So apart from that, active surveillance brought anxiety, but it also brought quality of life because we could avoid the side effects of the radiotherapy and surgery. And better quality of life, like I hope that you might observe, also motivates patients and physicians and also governments to improve by research on risk markers, imaging, genomic markers, better diagnosis and management. So only by following this improvement circle, we can reduce the need for active surveillance, only recognizing the really harmful cancers, but also we can make active surveillance better. And we need a worldwide community because numbers count over here, because it fastens our understanding of the slow growing disease. But we've also seen, and we can of course understand it by looking at the world graph, that there is no one size fits all, because there are genetic differences, there are cultural differences, there are lifestyle differences, and we have to incorporate all of these into our advices for our patients. So no wonder there are different protocols, because there are different patients all around the world. And we have learned to recognize that during the GAP program. The continuation of research is therefore needed. In Europe at this moment, we are studying MRI for the follow-up, and MRI is rather cheap over here, and therefore it has been popularized very rapidly, also introduced into active surveillance. We are doing the analysis of the biopsy genomics together with Australians and the North Americans. And we are evaluating the risk algorithms that predict outcome. And I will show you in a moment how that looks like. But as I told you, all of these elements are just part of your risk prediction. What is happening next year, in 5 years' time, in 50 years' time? What we want to do at this level, having seen and learned so much of active surveillance the last 15 years, is that we want to also reach out with these statistical results on a worldwide level and approach the current patient's needs for that. And those needs are not only, of course, in getting to know the risk of reclassification at the next time you visit your doctor. Those needs are probably also in what can you do with lifestyle, and we need information for that. What we've learned over the years is that, as I mentioned, PSA changes are traffic lights. They are indication lights. They are not the introduction towards intervention, but for diagnosis. The MRI upfront is good, but for the follow-up, we still have to learn something. The targeted biopsies obtained by the possibility of MRI are there, but many physicians are still reluctant to avoid the systematic biopsies, especially at the early age of active surveillance monitoring. Although patients would like to avoid those biopsies, of course. All Gleason scores are not the same. 6 is safe. As long as your tumor is a 6, it will not metastasize. And it is independent of the number of cores obtained from a prostate, as we depicted at this moment. Gleason 7 can be allowed, but on certain conditions, and we know that the Gleason 7s run more risk. So you have to realize that you have to visit your physician in order to be checked. And the extra biomarkers, especially in the Asian countries, seem to contribute to the better risk assessment. What do patients want? We are now active acquiring the needs of patients to improve our websites. There are many websites from many institutions around the world. And at some point, we'd like to bring some unified information, at least, with a more personalized view on how to monitor the patients on active surveillance. We would be very helped in the GAP program, the Mondial program of active surveillance, to obtain the direct patient's needs on the information they want to see on the website. Please fill up this survey monkey. This is my last slide. It's a difficult slide because it shows many things I said in one picture. But please recognize the blue arrow over here, the blue box over here, because this is where we'd like to work. We would like to give every patient on active surveillance a personalized view on their status and their risks of the near future in order to give an advice how often and with what to screen. And we are not there yet, but this is our aim in the Global Action Plan of Movember. And by obtaining all the information and using all the information over the 15 years from the past, we are able to make a start with this. So we would be happy to discuss this also with you, keep discussing this with you in the near future, how to realize this in order to get rid of the protocols, but really get to a more personal patient need view and monitoring. I'd like to stop over here, Howard. I thank you very much for this opportunity to present. I hope it offered things to patients, to people that have been listening, and I'm very open to the questions. I'll open the chat box in order to follow.
Well, Chris, the virtual hand clapping is thunderous. So we appreciate your sharing your views on AS, maybe different views than we would hear from our own doctors. We're going to move on to questions. I will ask a few questions, and then Phil Siegel from Toronto and Jeff McLennan from California will field some questions that came in from the audience, and we'll rotate. And I'll kick it off. But one thing we really didn't talk about, and we don't need to get into great depth, is, how is active surveillance handled where you, I believe you have a largely government-supported socialist system. in Netherlands? You know, are the incentives different for surgeons, let's say in the United States versus a location like Holland?
Indeed, Howard, we are based on a tradition of a socialistic approach of healthcare. And it means that every person in the Netherlands, but often very many countries in Europe, is offered an insurance, whether on a national health base or on a private base, but affordable. And that covers also the active surveillance and therefore the screening, at least in the Netherlands. Remarkably, in the Netherlands, although it was the grandfather of the European screening, screening in the Netherlands is prohibited. It can only be done on the base of a patient asking for screening. So the patient's position is very central, and otherwise it cannot be offered. So it's being controlled by the legal authorities in order not to run into over detection, over diagnosis, and over treatment. So the population is, let's say, protected by overactive doctors.
Well, let me be sure I understand this. So if I were a patient in Rotterdam, I would have to ask for a PSA. My doctor would not, you know, offer one to me, or would not automatically take it as part of a blood panel?
Legally, that is true. And let's say on the practical level, a doctor always needs to discuss the benefits, but also the harms of screening. And I think that we are aware that active surveillance is a side effect of early screening. And therefore, doctors that are offering or would like to discuss PSA with their patients, or patients asking doctors, should I do my PSA, always need to have an intensive talk, discussion, and information on active surveillance, because the doctors know that they might run into a situation in which this is becoming relevant for their patients.
I hear you. Well, I'm going to turn it over to Phil. Phil, do you have some questions?
I do. I'll just try and categorize some of the questions, but someone said that he wanted to know whether he's correct, that he heard that as many as 70% of men who are initially diagnosed could possibly be candidates for active surveillance. But that also goes with something that Dr. Bangma stated, that 50% of men who start on active surveillance will eventually leave active surveillance, and perhaps you want to comment on that.
Yeah, the first number quoted was 70%, and I'd say from the population studies of screening, we found 50% of diagnosed cancers are low-risk cancers. That is correct. So if all those patients would go on active surveillance, then we find out that reclassification into a higher risk and therefore treatment gradually goes on with time. So after the first year, approximately 20% of men on active surveillance are being reclassified with a more aggressive tumor, and therefore leave active surveillance and go into curative treatment. After 2 years, this will be 30%. After 5 years, it stabilizes approximately around 50%.
But that's due to the reclassification as opposed to the anxiety issue.
Yes, about 10% of people still choose active treatment because of anxiety, as we noticed. So anxiety is a confounder in these studies. And the anxiety can be raised as well as by physicians, by the way they represent active surveillance or their motivation for it, as well as by patients or their families, their spouses that are too nervous about going to a doctor every time, waiting for results, etc., etc., and also doing repeated biopsies. Also, this might sometimes be a factor that patients take into account in order to say, well, I want to have now the final curative treatment.
Okay, so I'll group together questions on biopsies and then I'll pass it over to Jeff. Over the age of 70, how often would you say men should be biopsied? And if you can also comment on the risk of infection and the effect of biopsies on risk of infection and erectile dysfunction.
Well, as I pointed out, the frequency of taking a biopsy depends on two things. One is, do you want to take a risk as a doctor or as a patient? If you are a risk-avoiding person, you would take a biopsy every year, like in the Johns Hopkins scheme. If you are feeling more flexible about it, you can do that every 3 years, like in the prior schedule. So in that case, you accept that there might be a 2% chance that you escape your correct treatment not in time, and therefore run up with metastases. So it's a matter of your own choice. The second argument is always, of course, how do the other factors look like? Is your PSA rising very quickly with a doubling time? It doubles within 3 years. Is your MRI changing? Is the pattern of your the lesion you can see on the MRI? Does it show aggressive features? And that might be the reason to change your the biopsy pattern of 3 years into an annual biopsy pattern. So it has all to do with taking risks and objectivation of risks. Now, avoiding infection, the second question is, I would advise everybody to stop transrectal biopsies immediately and do all the biopsies by means of the transperineal route through the skin. Stop damaging patients with infections that are not needed. The infection rate by transperineal biopsies is something like 1%, and the hospitalization for that is even less. Hospitalization for systemic antibiotics is even less. And by still using transrectal biopsies, this risk is at least 5 to 10 times higher.
Thank you. Just one, okay, I'll just pass over to Jeff, but one comment. Howard, you may want to make a comment now about a future.
That's, boy, Phil, I think we're having a mind meld because I was going to interrupt you.
Yeah.
We have another program that I hope you can all make, including Chris and Mike, and that'll be on April 30th, where we're going to have speakers from Britain, from Guy Hospital in London, and an inventor, urologist from Virginia. And we're going to be totally focused on transperineal biopsies. And it's funny, I had that on my list of questions I was going to ask Chris about, but I wonder how long has transperineal been standard in Netherlands?
Well, I think it's becoming standard now. Unfortunately, there's still doctors in small hospitals who do not have the equipment or do not want to spend the time for the patients to take these perennial biopsies. But I can assure you that at this moment, at least 50% of the biopsies in the Netherlands are taken by the transdermal, transperineal route.
Yeah, now in UK, it's about the same. But in the US, where some of the newer techniques were developed, it really hasn't caught on. And that's something I don't know that you have an answer to, but I wonder why.
We were also rather reluctant. And it also has to do always with costs and time and experience. We were reluctant because we thought it would interfere with our practice dramatically. Because, for example, we could not do the biopsy the same day as the patient would come in. But remarkably, after some experience of maybe something like 3 to 6 months, this goes as fluent in our logistics and our practice as before when we did the transrectal biopsies. So I don't find any argument anymore to keep to transrectal biopsies.
No, I'll just butt in one more second. I was talking to Dr. Ola Bratt in Sweden, and I was surprised. He said that he uses transperineal approach. And just just to be sure everybody knows what we're talking about, most of us have had transrectal biopsies. In this, Dr. Popert in Britain calls those transfecal. That's a little bit of humor for Mark, but in Sweden, Dr. Bratt said it's been a slow introduction, and he uses the approach selectively. Let's say patients that are at higher risk of infection because they're immunocompromised or they have diabetes. I mean, does that make sense? Does that approach make any sense to you, Chris?
Well, there is a saying also in Dutch that friendly doctors make ugly wounds. And it says something, if you don't want to be radical, then you keep with sticking to old-fashioned practice that still harms patients while it's not needed. So there's always factors and arguments to slow down a certain change. But I think that the world has seen by the work of the Brits and North American institutes, some European institutes, that the quality of the transperineal is far above that of the transrectal, and patients, I think, should be advised to ask for it, to ask their doctors, and to force this ugly practice to change.
Yeah, and maybe just to clarify too, what are the main advantages of the transperineal? Do you have no infection rate, or?
There is another advantage, and that is that actually the tumor sampling is better.
Yeah.
There's many, there's quite a bit of analyses now ongoing, but especially at the apex, so at the top of the prostate, it's difficult to reach with a needle by the transrectal route. And of course, by the introduction of the MRI and the visualization of lesions, we now know better where these lesions can be found. But the transperineal route avoids actually this sampling error that the transrectal route has. So it's technically, we think it's also better.
Well, let's see, I guess I should turn this over to Jeff.
Thank you. Thank you, gentlemen, and everybody in the audience. We're having a great day. I appreciate everybody's participation. Doctor, I have 3 questions to present to you. The first one has to do with one of the indicators called Psa density. Could you educate us in regards to how effective this indicator is, and if it should cause worry, or should it be just part of the mix of information practitioners use?
Yeah, Psa density is increasingly recognized as an important risk denominator. Because what does it do? If you have a large prostate with a lot of PSA in your blood, then it means the high level of the PSA is just due to the fact that there is a lot of prostatic tissue. So it is as simple as that. So everybody can understand when there is a high PSA and there's a small prostate, that this density goes up and therefore makes a risk factor for the let's say behavior of this cancer. It is as simple as that. And for the act of surveillance, it is in fact the same. It is a powerful statistical risk factor, much better than the simple level of PSA. It corrects that simple level, but the most important risk factor is, of course, the Gleason score at this moment.
Okay, thank you,
Does that answer
Doctor.
your question?
Yes, yes, thank you. I have two more questions. One of them has to do with the MRI and gadolinium. We have heard that gadolinium, perhaps some of the mixtures they use may be harmful to men in the long run, such as showing up in brain tissue when only indicated for the prostate. Could you please inform us on the use of gadolinium and its risks in the MRI of the prostate?
Yeah. This again is also a difficult issue in terms of, let's say, cultural appreciation. If I just say that in the Netherlands, the gadolinium reports on the accumulation in the brain tissue and the long run effects it might have in a subset of patients, has not led to an outward use of gadolinium, because the risk of using it is so small. But in a healthcare setting in which legal claims are very often being made based on scientific reports, and well, these kinds of reports that it might accumulate, I can imagine that people are more careful and more anxious to use the gadolinium in their MRI. Then there must be, of course, an alternative. And the alternative, as far as I know, is more costly. So then we run into very, let's say, unbalanced discussions about what is more important. So the short answer is, at this moment, we do not have an indication that the gadolinium being used for active surveillance patients is of large importance for long-term outcome on the brain.
So would you say that that means it is not a risk, or it is just not of importance?
It's not of importance.
It's not of importance. Okay. Thank you, Doctor. The third question has to do with the duality of the MRI and the biopsy. We have heard that the MRI can be used with what they call an in-bore biopsy. So the part of the question is, should the MRI and the biopsy be married or used together? And then the second part of that question is, since we have, if you will, a more powerful imaging in growth, in development of the MRI tool, how many biopsy, what I call pokes or samples, must be taken? If we have an MRI and it sees so much, why do we have to use an invasive biopsy in addition to it?
No. Well, the MRI issue takes a lot of presentation slides probably to explain it well, but let me try to go ahead. There are various systems to approach and target by biopsy a lesion that is recognizable on the MRI. This can be in bore, and that needs a very difficult and costly tool, instrument to do so, because if you want to do it in bore with an MRI, you need plastic needles in order to be able to handle that in a magnetic field. So therefore, translations have been made from MRI to ultrasonography, and that means that the MRI can be depicted on the ultrasound, and the ultrasound can be used as a guide for directing the biopsy. There's a lot of discussion amongst professionals, because most professionals say, well, I can direct my biopsy very well without extra equipment. I can look at the MRI, I know where the tumor is, and there I can guide my biopsy needle. There's still, to my surprise, a lot of reports that confirm this approach, the freehand approach, and also mentioned here the systems for taking biopsies, and they work well. They probably only work well if the tumors are large enough, let's say of 1 mil, and the chance of missing them therefore is smaller. And together is the fact that often these series are accompanied by systemic biopsies on top of the targeted biopsies, shows that these cancers, or the cancers that are present, cannot be missed by the biopsy. So the final answer is not yet out about the technology, but also not about the number of biopsies. Now, if you have a lesion, most professionals say 2 to 3 biopsies from that lesion is sufficient to make a diagnosis. But how many systematic biopsies do we have to offer? Because about 10 to 15% of the cancers are being missed if you only take targeted biopsies. And we don't want to miss that. So there you probably have to discuss that with your physician, what you want to do. And also where you are in your access surveillance monitoring scheme. And this is where the personalized approach comes from. If you have 3 times biopsies already and targeted biopsies, and you know that the target of your biopsy is in the lesion, and all those times there's nothing else being seen, there is an argument, of course, between the doctor and the patient to say, well, next time you take a biopsy, leave the systematic biopsies out. Please only do my targeted biopsy. We do not know yet, because we do not have the follow-up time of 15 years, how well that addresses the diagnosis. But we do know, of course, that that your monitoring is, of course, a balance between what is convenient and what is the risk, and what do you decide with your doctor. So we can only observe all of these things and hope that we will find out that MRI, after 1 or 2 times, can show us the relevant lesion and can reduce, therefore, the number of biopsies.
And we're talking about transperineal biopsies, yes?
Yes.
Okay, thank you, doctor. Thank you, Howard. That's the
Okay.
questions I have for now.
Okay, well, let me bring up a question I read from somebody in the audience. I thought it's a good one. Is there a certain age that people should stop taking biopsies? I know there have been guidelines, at least in the United States, saying, stop doing it at age 69 or something like that. And, I'm no big fan of biopsies myself. I think I've had about a half dozen, and but I haven't had one in 4 years. And I said to my doctor, well, when can I get off the biopsy train? And he says, well, he bases it, he uses a formula, a nomogram, to determine your age, or he eyeballs you. And if he thinks you're going to live another 10 years, that's the good news. The bad news is he might recommend another biopsy. So what is your approach on that?
Well, in the early stages of active surveillance, we had these strict protocols in order to obtain enough observations to make these kinds of predictions. When do we have to stop? Nowadays, we are personalizing also, like with the former questions, this approach of biopsies more and more, because we are there for the patient's convenience, not the other way around. At the same time, of course, we putting down our observations into our databases. The great difficulty, Howard, as you say, is that your doctor is eyeballing you, saying, well, how long is this patient going to live? If we are doing active surveillance because at some point at reclassification, we want to offer a curative therapy. If a curative therapy is not feasible anymore, or is not useful anymore because of life expectancy, why do active surveillance? Why continue active surveillance and do biopsies? Then just monitor the PSA. And if you're lucky, your PSA goes up every day, every year, a little bit, but it doesn't lead to a symptomatic tumor.
Yeah,
So,
Chris, yeah, I'm sorry.
Yeah, the eyeballing is important, but we don't have any measure of survival time for an individual patient. Very rude approaches.
Yeah, Chris, you know, we're almost, well, we are exactly at the time we said we would break up, but I wonder if you'd be willing to hang in there with us for another 10 or 15 minutes and take some more questions.
I'm very happy to do so, although you see that evening is falling over here and it is obscuring my my camera a little bit. So I put on the light over here.
Okay. So, you know, there's a debate that's an old debate, but it's being revived by Dr. Klotz in Toronto and Dr. Egner in Chicago, calling for reclassifying Gleason 6 as non-cancerous. And we know from Dr. Epstein at Johns Hopkins, he's the pathologist. He thinks this is a bad idea. And I know one of your slides kind of showed, you know, the difference between Gleason 6 and above. But I mean, years ago, I think any Gleason score was considered a cancer, and they redefined those, and they made Gleason 6 the floor. Can you see Gleason 6 being removed and being redefined as non-cancerous?
Well, I think it can be removed, but there have been very many attempts in order to rename it as a low aggressive or low risk tumor and all kinds of abbreviations for it. I think actually what is going to happen is that, which I hope, of course, is that the genomic studies will classify the Gleason 6 better, and therefore will make a classification of the very few that might become relevant, and therefore can give us a clue to abandon all those Gleason 6s that, due to their genetic pattern, will not become of relevance during life. And then they will safely be removed from classification cancer, but not before that, I'm afraid.
Now, we got a question in here from someone in the audience saying you didn't mention any risks or side effects of transperineal biopsy. What are the side effects?
Well, the side effect is, as I mentioned, a very low infection rate, urinary tract infection rate, with very exceptional hospitalization for systemic infection. Depending, of course, always on the number of biopsies, the intensity of hematuria, which is harmless, but anyway, it doesn't show well. Hemosparia, so blood with the ejaculation, or the swelling of the prostate and therefore temporary obstruction with voiding problems is of low rate. And as we can see, the hematuria is at the moment something like 25%. The obstruction or the micturition alteration is something like 10%. This is all temporarily, it's harmless, it's only of, let's say, it's not nice for patients to observe.
Howard, could I interject a quick one that follows up on that? So
You're the boss.
since this is not a transfecal biopsy, does one then avoid having to take antibiotics, which we are all increasingly concerned about?
That's a very good question. And I'm ashamed that I didn't mention it. That is one of the great benefits of the transperineal biopsy. In Holland, we are not using antibiotics anymore for a biopsy, unless a patient is diabetic or has another high risk factor for infection. So that's interesting. And still we are observing these good numbers about infection rate. This dramatically brings back the multi-resistant bacteria, which we are observing very well here in the Netherlands, and therefore would help us to reduce the resistancy, antibiotic resistancy of the bacteria that are in our population, especially in elderly homes, etc.
Well, Mark, can I butt in again, or you have something? Oh.
I muted myself, but that was perfect. That's what I expected. That's good news.
Yes, it is.
You know, I'd like to follow up on a question from somebody in the audience having to do with MRI. He's saying, what is the likelihood that the MRI will miss some cancers? What is the risk of relying on MRI only? And I'd like to make a point that the way I understand it, the MRI is much better at finding more aggressive, bigger cancers, and is less effective at finding the low risk cancer. So from, is that almost an advantage of the MRI?
Well, I think it is an advantage. And as you say, the MRI is incapable of finding tissue that does not differ enough, doesn't have an ugly face enough in order to be recognized. So the nice face cancers, they look alike like normal prostate tissue, and therefore the MRI cannot see. So a negative MRI can be interpreted as a good sign. For example, during your follow-up. And therefore, the negative MRI might be a very good replacement of the biopsy in the end. But the early analyses of the MRI series have shown to us that we still risk, by doing so, 10% of the tumors that would reclassify. That is still a rather a high risk. So the stakes are still there. We don't have a solution yet for this problem. And so if you want to rely on the MRI, people are doing that after 2 or 3 times that they had a biopsies and are pretty sure that the cancer they had in the previous diagnostic phases did not spread all over the prostate and were visible. But if you introduce it from the beginning, I would not advise my patients to rely only on the MRI.
Although some doctors do rely only on MRI. And, you know, I've heard that in the United States, and some patients are followed with PSA, and if there's a rise in PSA that's concerning, then they would have an MRI, and then that could lead to a biopsy. But, you know, if there's no significant rise in PSA, they can, you know, just kind of do a different kind of surveillance and actually never be diagnosed with prostate cancer. Am I making this up, or does that make sense?
No, it makes perfect sense. Two things I would like to say. It would be very valuable to have those kinds of observations in a long-term database, because then we can advise other patients about it. The second thing of it, I would completely agree with it, but not as an initial approach for monitoring. I would rather be safe than sorry, and offer my patients at least 2 or 3 times a biopsy in order to be sure that I'm not missing a relevant cancer at the beginning.
Gotcha. Now, somebody else asks, do targeted biopsies work the same with transperineal versus transrectal?
Sorry, once again, Howard.
Yeah, if you're having a targeted biopsy, is it does it make any difference whether you're having a transperineal or a transrectal?
No, as long as it is in the target, it's the same.
You know, and you know, if some of the other moderators want to jump in, they can feel free, but you know,
I have a question.
Yeah, go ahead.
What is on the horizon, doctor? One of our participants wants to know what to expect in terms of new technology and new indicators for managing active surveillance.
Well, I think that the highest chance that active surveillance monitoring will be altered is by means of the genomic test. But we still have to know how to use it.
So
I could not think of any other imaging approaches, because the MRI is so good, so well developed already. So it needs maybe better doctors, but not better technology to interpret.
Along those lines, what about PMSA or liquid biopsies?
Well, both of them are very relevant in the more advanced stages, because the pictures you're getting, the images you're getting from the PSMA at this moment are very rude. They are very general. It's a fleck, a large lesion into a prostate. So for early recognition and follow-up, it's probably insufficient. This is different for stages in which there are, for example, lymph nodes or other places, lesions, to be recognized and have to be monitored. So that is in later stage disease. So that's what about the PSMA. The liquid biopsy relies on the circulation of free DNA or of prostate cancer cells in the blood. Well, the latter, the cells in the blood, I think we have been convinced the latter years that counting the circulating cells amongst trillions of blood cells is a very difficult thing. And it shows a large variation. It's not useful for early diagnosis or decision making in curative treatment. The free DNA depends very much on the, let's say, alterations of DNA that are in the prostate cancer. And although prostate cancer has a rich genomic field of alterations, and very many alterations in prostate cancer, they vary tremendously amongst patients. So there is hardly one that fits all. And for free DNA to be recognizable or as a test in the blood, you really need a good subset of patients to recognize that altered piece of RNA DNA that connects to prostate cancer. So the test of the liquid biopsy should be a test that recognizes several pieces of DNA. But at this moment, we are not aware of which pieces that should be.
I hear you.
Let me interject, if I may, with a follow-up there. By the way, Chris, I feel like we need to be respectful of your time here, so maybe we should wind this up. But let me finish with my question. The micro ultrasound in the States is beginning to get a little bit of traction. I haven't heard you speak of the micro ultrasound as a monitoring device. Any thoughts about that?
Yeah. Well, also in Europe, it's in early stages. I regularly see, for example, a small series from Italy, from France. We recently had this week even a symposium about it. So yes, it's trying to find its way, but it is not being tested extensively in active surveillance as yet. So I think it's an early phase, and I can't say too much with certainty about it. But of course, we're very hopeful, because if we can get rid of the MRI, that would be convenient for our patients. Still, I doubt whether the sensitivity of the MRI easily can be mimicked by the ultrasound.
Thank you.
We'll have to see.
I feel as if I don't want to take advantage of Chris. Chris has donated his time to us here, and we're grateful for that. So,
well, some people wanted to send Chris a note. I wonder, Chris, if you could put your email address in the chat.
Yeah, sure.
Jeff, if you wanted to say a couple of words, and then I'll say some final words.
Thank you, everybody. I want to apologize. We were not able to get to all of the questions. We'll do the best we can if we can follow up with the doctor. But it's very important that we get some funding from any of those of you who can afford to send us money. There is a donate button on our site. We are totally volunteer. We have no paid staff. So we do the best we can, but we want to improve our service to you. So as you know, funding helps reach more men, including the doctors who are here today and their generous time. So please donate if you can.
Thank you. Chris, this was outstanding. I learned a number of things, and I really enjoyed your manner. There's a certain humility about you that I really appreciate, and it comes through quite well. And I wanted to thank the team too for creating this, putting this together. Howard for finding Dr. Bangma, and the audience as well for being here with us. The great questions you asked, very insightful questions. We too we're always looking for volunteers, and actually at our next meeting, we have different approaches. Our next meeting is going to be a town hall, and we'll have probably 4 active surveillance patients from different countries speak of their active surveillance journey. So if any of you are interested in being considered for that town hall or a future town hall, I put my email in the chat box, and you can get in touch with me on that. The next meeting is going to be at noon on March 27th. So we'll be in touch with
Yeah,
you.
well, I noticed that we had people from some countries we haven't seen represented before, like Belgium and Germany. I didn't go through them all, but if some of those people especially want to speak up, they should reach out.
Yeah, it'd be good to have different countries. Anyway, would the folks on the program team stick around for just a couple minutes, and the rest of you, auf Wiedersehen, farewell.
Well, you sound like Joel Gray and
Hey, Doe,
Cabaret.
hey, Doe, if you're from Sweden, I lived in Sweden. And thank you.
Bonsoir. Bonsoir.
Okay, take care. Thank you. Thanks
Hey,
again.
Chris, thank you.
Thanks,
Buona
Chris.
sera.